Welcome. My name is Elizabeth Topper. I'm a research professor here at the Bloomberg School of Public Health in the Department of Epidemiology, and I'm director of the MAS programs. And it is my pleasure to welcome you today to the first in our MAS seminar series. We're really excited to kick this series off, even though we're really close to the end of the calendar year, hopefully in advance enough of the end of the term. That we can still gather, which is really the point of the series, is kind of twofold the way I see it. We created this one to create a space for our online community where we can gather outside of the context of a specific course and just get together and talk about public health, and also to highlight the work that's being done by our faculty, our alumni, our students, so that everyone can continue to grow their professional networks. So with that, once again, I welcome you, and I'm thrilled to welcome our speakers today. We have Dr. Mark Bittle, who is the program director for the MAS and certificate programs in population health management, and Zack Royston, who is one of our esteemed alumni, and I will welcome them and ask them to introduce themselves.
Great. Well, thank you. I appreciate it. The opportunity to be here today and talk about applying principles of population health management in rural communities, a case study with my colleague, Zack Royston. So Zack, if you want to go to the next slide, please. There we go. So our seminar today is really going to focus on a few things. I'm going to give a brief overview of the challenges of rural health and healthcare in the United States, talk a little bit about the population health improvement roadmap, and then again, I'm going to turn it over to Zack to talk about the very innovative things that are happening in University of Maryland, particularly in Shore Regional, a rural health setting. So all of you know me. My name is Mark Bittle. As was mentioned, I'm the program director and founder, if you will, of the Population Health Management Certificate and Master's Program. I'm a teaching professor here in the School of Public Health in the Department of Health Policy and Management. And I also took over recently chairing our school-wide DRPH program. Zack?
Sure, thank you, Mark. Zack Royston. I'm recently transitioned within the University of Maryland Medical System to the Vice President for Rural Healthcare Transformation with our Shore Regional Health System, and I'll talk a little bit more about that. And also I'm the Executive Director for our Shore Medical Center in Chestertown, which was the first designated rural hospital in Maryland. Again, we'll speak a little bit more about that. Also very grateful to be an alum of the program from 2023, and this has served me well for this new role I'm taking on with the University of Maryland. So I'll pass it back over to you, Mark.
Okay, great. Zack, next slide then. All right, so I am going to start off with, again, just a brief overview of some of the challenges in the rural health setting. In 2020, a report by the advisory board declares rural health care is in a state of emergency. Ironically, in 1911, C.W. Stiles, who's a zoologist and public health official, essentially declared the same thing, surfacing the many disparities and challenges that we see today. For the first part of today's talk, I'll discuss the unique and quite persistent challenges faced by rural populations and healthcare systems, providing a few facts related to the significant health disparities in rural areas, barriers to healthcare delivery, and the challenges faced by rural healthcare delivery systems. I'll include a brief discussion on the Bloomberg School of Public Health's population health management framework as a model for addressing these challenges, and then turn things over to Zack to share his experiences using a case study. Next slide, please. So let's begin with a quick look at healthcare disparities. Rural communities make up approximately 20% of the U.S. population, yet they experience worse health outcomes compared to their urban counterparts. Key health disparities include prevalent chronic conditions and increased mortality rates amenable to care. Rural Americans are more likely to suffer from chronic conditions such as diabetes, hypertension, and heart disease. A greater share of the rural population, nearly 18%, is 65 years and older compared to just 14% in the urban population. They experience a higher mortality rate for preventable diseases. For example, the CDC notes that rural areas have a 20% higher rate of premature deaths than urban areas. There's a lack of access to preventative care. Preventative care is less utilized in rural areas due to limited healthcare resources. According to the Kaiser Family Foundation, vaccine rates and cancer screenings are significantly lower among rural residents. There's inadequate behavioral health and substance use services. Mental health services are scarce. Suicide rates in rural areas are 40% higher than in urban ones, compounded by the opioid epidemic, which disproportionately affects these communities. For example, rural youth have a 35% greater chance of misusing prescription opioids, and rural children ages 2 to 8 years old have a higher prevalence of mental, behavioral, and developmental disabilities. Impact of social determinants are also prevalent. We need to think about rural populations facing higher rates of poverty, having lower educational attainment, and experiencing higher unemployment, all of which contribute to poor health outcomes. About 76% of the counties with the highest prevalence of food insecurity are rural. And while rural homelessness is often overlooked, rates are increasing faster in rural areas, and a greater share of rural people experiencing homelessness are unsheltered. These disparities highlight the urgent need for systemic changes to better support rural populations. As we consider the barriers to healthcare delivery, we need to consider several key factors. Of course, geographic isolation is crucial. Long distances between healthcare facilities are a significant challenge. On average, rural residents must travel 17 to 40% further than urban residents to access primary care services, which, as we know, impacts timeliness of care and exacerbates health issues. There are healthcare workforce shortages everywhere, but they are particularly evident in rural areas with critical shortages of health professionals. Nearly 60% of rural counties lack a psychiatrist, and more than half lack a pediatrician, according to the Rural Health Association. There are limitations in infrastructure. According to the Office of Management and Budget, approximately 46 million people, or 15% of the population as of the 2010 census, resided in rural areas, while over 72% of the U.S. land area is designated as rural. Compared to urban areas, rural areas have a higher percent of older adults, higher incidence of health disparities, lower patient volume in healthcare facilities, and substantially poorer healthcare infrastructure, including telehealth adoption and health information technology system capabilities. Many of our rural hospitals and clinics struggle with outdated facilities, limited broadband for telehealth, and insufficient funding to upgrade services. Economic barriers persist, such as high rates of uninsured and underinsured individuals in rural communities, which create financial obstacles. And as we know, that may delay or forego care because of these cost concerns. This may surprise you, but average premiums are higher in rural counties than in urban counties. In addition, rural counties are more likely to have fewer than 3 firms participating in health information exchanges. Medicare Advantage plans, copays, and deductibles are higher in rural communities, and no-cost benefits like health clubs and transportation are less frequently offered in these rural areas. And finally, we have to consider the cultural and social factors. Cultural stigmas surrounding mental health and chronic conditions prevent individuals from seeking care. Additionally, rural residents often prefer local providers, which, as we know, may not be available. And finally, health literacy impacts a patient's ability to understand health information and instructions from healthcare providers. This can be especially concerning in our rural communities where educational attainment, as we know, is lower than in the urban setting. Next slide, please. And finally, let's look at the challenges faced by rural healthcare systems. As indicated in a report by the advisory board, the challenges these rural providers face are both wide-ranging and well-documented. We saw this from C.W. Stiles' initial report in 1911, but too often the conversation stops at simply defining the problem. You can't pick up an edition of Modern Healthcare or Health Fairs without reading about hospital closures. As of 2020, more than 450 rural hospitals are indicated to be financially unstable. Nearly 47% of the 1,800 plus rural hospitals operate in the red, which is up from 39% in 2015. According to Kaufman Hall, these closures are driven by financial instability, low patient volume, and reimbursement challenges. Speaking of reimbursement, rural providers often rely on Medicaid and Medicare, which reimburse at lower rates compared to private insurers, placing a financial strain on these systems. Medicaid covers 24% of the non-elderly individuals in rural areas compared to 22% in urban areas and 21% in other areas. We know healthcare networks are often fragmented, but we see this even more so in rural communities. Rural healthcare systems frequently lack integrated care networks, limiting their ability to coordinate care across multiple providers and facilities. We've already talked about the difficulty implementing technology. While telehealth has shown promise in addressing rural access issues, many areas lack the broadband infrastructure needed to fully utilize that capability. This digital divide remains a significant challenge in our rural settings. In addition, the expansion of telehealth services can have the unintended consequence of allowing urban centers to actually access rural patients, taking that business away from rural providers. And finally, emergency preparedness. Many rural hospitals are ill-equipped to handle public health crises such as natural disasters and pandemics, further jeopardizing rural health outcomes. Next slide, please. So in this brief review, we can see that the challenges of rural health and healthcare delivery are multifaceted, touching on economic, social, and infrastructure variables. Population health management strategies do offer a way to systematically address these unique rural health challenges. To improve rural population health, there must be a concerted effort to focus on proactive care, integrating technology, leveraging community partnerships to address the social drivers of poor health, and align care delivery models to the unique needs of rural populations. In our population health management program at the Bloomberg School of Public Health, we provide practical strategies following the Know, Engage, and Manage framework. In each domain, evidence-informed practices to identify the needs of a population, strategically engage constituents in the thoughtful planning and execution of innovative solutions, and managing care across the continuum of health needs are central to our curriculum. In the next part of this discussion, my colleague will share with you how these principles can be operationalized to not only improve health outcomes in rural areas, but also assure the sustainability of the rural healthcare systems. Zach, I'll turn it over to you.
Great. Thank you so much for setting the stage, Mark, and sharing that background information. A couple of other quick just housekeeping items. If you do have questions, please enter them into the chat, and we will spend some time at the end of the session working to answer those. And for those of you who are in the program or starting in the program or an alum, the one assumption or background piece that overlies what I will be speaking about in terms of our experiences with the University of Maryland and Shore Regional Health is this is all happening within the Maryland model. And the Maryland model, as I'm sure you've heard, is different and could occupy hours upon hours of conversations, in particular, changes that are happening because we are going to be tackling the CMS Ahead model coming up shortly. And there's a lot more pressure on our population health strategies through this total cost of care and the Maryland model that we won't have time today to dive into. So I just want to sort of keep that in the background because I know those experiences may be very different than what many of you are encountering in your local areas based on payer reimbursement and negotiations and value-based care models. So with that, let me spend a little bit of time talking about our experiences with University of Maryland and our Shore Regional Health System. The takeaways, I'll go through key takeaways, sort of share them up front, and then that way, if you have to leave or venture on, you'll at least have the highlights to walk away with. We'll do a little bit of an overview of the system in which I'm currently working, Shore Regional Health, which is a part of the University of Maryland Medical System. We'll talk a little bit about the rural healthcare transformation journey that we've been on with Shore Regional Health, our activities and partnerships, and then some of the work that we're doing beyond what a lot of organizations focus in with the Patient Family Advisory Council activities, and some of the things that we've decided to engage our community differently around, in particular to try to help address some of the health disparities that Mark highlighted within his background information. So here are the key takeaways, and I think these are sort of self-evident based on all of the statistics and references that were shared at the beginning of this talk. Transforming rural health is hard. It is an incredibly challenging journey. It is a very costly journey, and in challenging economic times, it can be one of the areas that gets a little bit left behind, depending on the systems in which we're operating in within our healthcare environments. University of Maryland Medical System and Shore Regional Health, we are looking to implement strategies that are innovative, integrated, and sustainable to, again, make sure that we don't start or initiate programs that then would need to be stopped or sunset, and then, sort of compound some of the challenges that were previously mentioned. Population health and addressing rural health within the context of a hospital-based academic medical center does require some time and attention and focus on looking at our ambulatory and outpatient services and engaging with the community to help address the concerns that arise. I'll share that we've recently broken ground on a new regional medical center that we think will be critical to revolutionizing our care delivery strategies on the Eastern Shore. And then, the focus of this program is engaging and looking at those principles of population health to make sure that we are approaching the problems from an evidence-based, academic, and peer-driven background. And I think that's one of the tremendous advantages that having this program today, being a participant in the program through Bloomberg, is creating those peer relationships and being able to draw on the strengths and experiences of others in other areas and bring those best practices and pearls and perils of wisdom back to apply within our local roles. And I'm grateful for those connections that I made through the program as we move forward. So the background image here that you see is a rendering of our new Shore Regional Medical Center. I'll speak a little bit more about that. But this has been a 25-year journey to get to groundbreaking for this. And that journey and 2 failed certificate of needs are sort of what were the impetus for a lot of the changes that were undertaken within Shore Regional Health to address our rural healthcare challenges. Shore Regional Health is a part of the University of Maryland Medical System. We are approximately $5 billion health system with about 30,000 employees. However, the Shore Regional Health System is geographically isolated from the main components of the University of Maryland, which are centered in Baltimore. So there is a bridge across the Chesapeake Bay, which is a 2-hour commute from either one of our hospitals on the Eastern Shore, or we have to go up and around when the Bay Bridge is closed, and then that adds a 3.5 to 4-hour commute for any patient transfers. So we have quite a bit of helicopter activity that takes place among our centers to help get patients to the appropriate level of care. Shore Regional Health itself we are about 2,000 team members strong. We have about 400 volunteers. I think we are fortunate that we have a high degree of volunteerism within the rural community from our aging population, and they serve to be greeters and stewards of our health services programs within the region. About 550 medical staff. We have about 69,000 emergency department visits, which is comparable to many of our other community health centers. However, those visits are happening across 4 different emergency departments. So that geographic spread is certainly one of the challenging elements that we have. When we think about workforce and shortages in workforce, and also the ability to staff and maintain appropriate levels of clinical care, in many of our rural settings, we have a lot of, there's one of something. And so that works fine during normal operating times, but, in the times of crisis or demand, it does, put significant pressure on our efficiencies and ensuring that we've got all the right linkages in place for patients to get navigated through the system. As a system for Shore Regional Health, which is really a system within a system, we cover 5 rural counties in the state of Maryland, which is approximately 2,000 square miles. To put that in context, it's slightly smaller than the size of the state of Delaware, which is adjacent to us. We have about 80 people per square mile. So in those 5 counties and 2,000 square miles, we're serving about 172,000 lives. Again, the state of Delaware is a little over 1 million individuals. And if you were to flip our geography over onto the western Maryland side, we would be covering between 2 and 2.5 million lives within our footprint. The University of Maryland Medical System provides 25% of all hospital-based services. We are the largest provider of hospital-based services in Maryland, and we are focused only on Marylanders in our mission in our delivery system. As Mark talked about, the challenges in terms of life expectancy and health disparities, we see that across our 5 counties in the Midshore, with 2 of our counties ranking amongst the bottom in Maryland in terms of life expectancy. And we have some of the higher racial and ethnic disparities as far as health-related social needs as well across our Midshore region. So the challenges are vast, and they are spread across quite a wide area. Pulling some of the data and looking at our area deprivation index from the Neighborhood Atlas, we can see that, nationally, a lot of the Midshore region isn't flagging as some of the most disadvantaged areas. But again, referencing back to the Maryland-specific data, you can see along in the Federalsburg, Cambridge, lower Dorchester County, again, we are in the top tier, top 10% of disadvantaged rankings in terms of our area deprivation index. So constantly seeking to try to figure out how do we close those gaps and improve our delivery to those communities. Turning a little bit of our attention now to the actual journey that we've been underway. I mentioned earlier, we had a groundbreaking ceremony October 21st for our new Shore Regional Medical Center. And I wanted to pull out the support that's been provided by the state of Maryland, and in particular, Governor Wes Moore, in helping us to achieve a solid and sustainable care delivery model for the Midshore, and his support for that regional medical center and expanding access to the Eastern Shore. So I'm not going to read his quote, but I think it is telling that, he recognizes that other states are struggling or sort of, backing away from the investments in ensuring healthcare access in rural communities. But he's made it a part of his platform to make sure that no Marylander is left behind in terms of healthcare access. So we are grateful to his for his support. Mark covered all of the challenges facing rural healthcare, and I'm not going to go back through these. But again, I will sort of layer on another component to this, which is doing all of this within the Maryland rate-regulated environment, and recognizing that the Health Services Cost Review Commission has levers around hospital reimbursement, and they're trying to continue to identify ways that through those hospital levers, they can influence the outcomes in ambulatory settings that are in the unregulated space and help drive primary care and specialists in our professional reimbursement models towards value-based care, population health, which I know are all components of the program that you've either heard about or will be hearing about, depending on where you are on your population health management journey with Bloomberg. This slide harkens back to my comment about sort of the 25-year journey into previously failed certificates of need. And basically through those certificate of need conversations, the pressure was put back on to say, it's great that you identify the need for a new hospital on the Midshore area. And that makes sense. However, we want to see a demonstrated commitment to the growth and sustainment of access to the broader Midshore and not just in our sort of Talbot County, Lower Queen Anne County geography. So that kicked off a series of events beginning back in 2017, where Shore Regional Health established the first freestanding medical facility in the state of Maryland, which is an emergency department, imaging lab, and medical office suite. And then from there, we've continued to expand our footprint across the 5 counties, adding urgent care centers. In 2021, the Shore Medical Center of Chestertown converted from a full access hospital to the Maryland's first rural designated hospital, which again, I'll talk a little bit more specifically about in a minute. And we did reach the conclusion based on, again, the analysis of the data that our Dorchester General Hospital would be better served by being a freestanding medical facility. So in 2021, we actually closed our Dorchester General Hospital, which was a small community hospital, approximately 25 minutes from our main hospital in Easton, Maryland, but did put in place, again, a freestanding medical facility with emergency department observation and lab and imaging services, as well as a medical office building. Our 5-county region is rather unique in that 3 of our 5 counties are without hospitals, and there's only 1 other county in Maryland that doesn't have its own hospital. So, we continue to identify how do we ensure access to care, continuity of care, and meeting those patients' needs and getting them to the appropriate level of care through these other approaches, and we'll get a little bit more specific about some of those specific population health approaches in a minute. I've referenced the Shore Medical Center at Chestertown. It's actually, I'm the executive director for this center. This was a full service hospital, labor and delivery, ICU, med surge. And there were conversations around closing this hospital altogether, potentially adding back a freestanding medical facility. The community, through a grassroots campaign, really had some feelings about that approach, and really lobbied hard to maintain the hospital. And part of the importance of that was the recognition that for the residents of Kent and northern Queen Anne's County, again, the next closest facility, emergency department and or inpatient services, was an hour away. And I know, probably many of you on the call are also in rural communities, and those distances may not sound, similar to what you're dealing with. And so I think, the recognition that rural healthcare, again, is hard. The geography, the distances all create challenges. But it was important to this community and to Dr. Mohan Santa, our CEO, that we maintain a footprint in northern Queen Anne's County. So what that ultimately ended up being was the conversion of this hospital to the first rurally designated hospital in the state of Maryland, which is really modeled after critical access hospitals. So you'll see here 25 beds or less, less than a 96-hour sort of length of stay. We have hospitalists, some surgical services, full imaging, emergency department. But what differentiated this a little bit from a traditional community access hospital was also the recognition of the demographics of the population served here. So Kent and northern Queen Anne's County is a population that is growing in the 65 plus faster than the state of Maryland than the national average. Currently, about 25% of the residents of Kent and northern Queen Anne's County are 65 or over. So part of the commitment in converting this to a rural designated hospital was bolstering our capability by layering in geriatric and aging-friendly services. So We have a level 3 accredited geriatric emergency department. We were the first in the University of Maryland medical system to have an accredited geriatric ED. We've since obtained that designation in 2 of our other EDs, Foreshore Regional Health, and we're working on the 4th for the spring. We are a designated level 2 age-friendly health system through IHI. And as many of you may be aware, CMS is actually going to be requiring through the inpatient prospective payment system beginning in January, hospitals who receive Medicare funds to embed as a part of their programs some of the characteristics of the age-friendly health system. So, that was, something we were doing back in 2021. And then we are a Healthy People 2030 champion, which again ties back directly to some of the information that's been shared in the population health program, and was recognized by Becker's as one of the top 100 community hospitals this year. Taking the attention now and sort of moving away from some of the hospital-based services and our how we meet some of the geographic demands, wanted to spend a little bit of time talking about 3 particular programs, our population health programs generally, our mobile programs, because we have 2 different approaches to mobile health, and then a medical transport solution that we've added here for the shore. So I'm not going to talk about all of the elements here, but I wanted to just focus in on those 3. When we look at our approach and, sort of go back towards the know, engage, manage framework, one of the strategic priorities of the University of Maryland medical system is around value-based care and to be a leader in population health. And so within our corporate population health team, which is the part of what I was a part of that team prior to coming to my role on the shore, we use this framework to help inform and guide our decisions around our approaches for population health, which has been shared and disseminated through our member organizations' population health programs as well. We've also taken lessons in terms of continuity of care and looking at the expanded chronic care model in terms of delivering care across the full continuum, recognizing that, again, hospitals tend to focus in on the high utilizer, acute care services. But we really wanted to take a look at how do we get to those individuals who have low or moderate risk stratification, and what are our approaches for addressing their needs along the continuum of care, recognizing that has not been traditionally an area where hospitals have focused their attention. So that's where our population health program has sort of picked up this model, looked at the risk stratification, and tried to provide programs and interventions across the full continuum, with a high emphasis on working with community partners, since they have additional resources and capabilities in meeting patients where they are and addressing their health-related social needs. Foreshore Regional Health, and part of the work that I'll be taking on over the next several months as I step into a little bit more active leadership role for our pop health programs, is we have some fragmentation across our pop health programs. So we have some hospital-based population health programs. Our Shore Medical Group has some population health programs. We have community health, and then we have our corporate population health programs. So part of my role is aligning and synthesizing the work across all of these sort of disparate groups to ensure that we're maximizing the use of the resources that we have available to us and making the most impact in the communities that we serve across those 5 counties. Looking at the Shore Regional approach to some of our population health programs, these have been traditionally led from within our hospital-based population health. I know many of you are probably using some of these same interventions and approaches within your communities. So this past year, we were able to, through grant funding, launch a remote patient monitoring program. So we have the capability of enrolling up to 100 individuals based on risk stratification and targeting chronic conditions of CHF, COPD, and diabetes. So we initiated this program in March. We've enrolled and managed approximately 80 individuals through the program, with the success stories of identifying those early vital sign indicators that somebody may be struggling in order to prevent utilization and reduce readmission for their disease condition. We have a transitional nurse navigator program and hospital-based case management. They are working to reduce our 30-day readmission rates, so that it's comprised of 4 nurse navigators and a community health worker. They are engaging with those who are identified as high risk, top 10% of utilizers from emergency department and inpatient utilization. And then they are providing continuity of care, transitions of care to primary care specialists, ensuring medication follow-up, medication reconciliation, and then coordinating with some of our other programs to go to patients' homes in order to monitor and support their needs in their environment, versus having patients having to travel across the geography that we span in order for them to reach healthcare services. So we do lean heavily on telemedicine for some of those work as well. Through these efforts, our 2 hospitals that comprise Shore Regional Health have the 2nd and the 4th lowest readmission rates among all Maryland hospitals. So we're pretty proud of our ability, given the geography and the challenges of the population and the disparities. We've also demonstrated a complete reduction in readmission disparity. So we have no disparity in readmission among our Caucasian, African American, or other ethnic or minority groups. So we've leveled that. So that was a change over the last 3 years that is pretty significant, because we did see a fairly high disparity among our African American and Latino community compared to our Caucasian white community for readmissions. Given the aging of the population, we've been very aggressive in launching an advanced directive campaign. Our team members are actively encouraging and working with patients to complete their advanced directives, helping them think about their decisions before their decisions need to be made. So we've done over 3,000 advanced directives in the last 2 years across our region, and we actually have, and you see here represented, we have drop box outside of all of our facilities for individuals to drop off their advanced directives, and then we'll get them scanned into and entered into the Epic system so that they're on file, so that patient need that information. And then from an outcome standpoint, we're looking at on the bottom right-hand side here, our Medicare inpatient days. Again, in Maryland, all things revolve around our Medicare population. And so Shore Regional Health, Easton, which is again our primary community health facility, has significantly lower compared to the state average inpatient days for our per 1,000 Medicare beneficiaries. And that's all through the efforts of these population health programs that we have at the hospital. Continuing on, chronic disease management, again, they're followed by our transitional nurse navigators. And we have developed across the University of Maryland medical system and within Shore Regional care pathways focusing on hypertension and congestive heart failure. So patients receive a standard approach to their care and those linkages for those 2 conditions, and we continue to roll out additional clinical pathways to support our patients. We have a NRC callback system, so 100% of our ED and outpatient or inpatient discharges are contacted by a member of our population health team to discuss any concerns or questions they have regarding their discharge within 48 hours. And they're looking for, again, those subtle early indicators that somebody may be having challenges and provide intervention in order to prevent unnecessary utilization. And so, for last fiscal year, we're July 1 to June 30 fiscal year. We had almost 8,000 individuals who were served through that NRC call where an issue was identified and resolved. So that's not the total number of people who we called. These are the number of people we had an intervention on based on a finding that came out from that call. And then lastly, we have a very engaged pharmacist. So, one of my peers in the program, Lee, I'm sure is who's a pharmacist by background, is excited to hear that, who is actually engaged in all of our communities across the 5 region doing, medication reconciliation, telehealth, teleconsults for medication reconciliation, and is a part of our mobile health teams for patient care. And I'll speak a little bit more about our mobile programs here in a minute. Oh, I'm going to back off of this slide for a second. So to set it up. So, we talk about in population health and certainly social determinants of health being a major factor, with transportation being one of the highest health-related social needs that gets identified for patients. I think one of the things that we probably appreciate as population health practitioners, especially in rural communities, is that in the communities we serve, our team members are our community as well. And so as we see health-related social needs within the community, those are, not so different for our team members. So we are constantly looking at ways to help support our team members with their health-related social needs. And then as a system, we have a transportation challenge, and I described the geography and the transit routes. So Shore Regional Health, our 5-county region, is only served by one ambulance service. We have a critical care transport service for the hospital, but our ambulance, we only have one private ambulance service that we work with. And, we're sort of past the days. I was previously a volunteer firefighter paramedic, where we would get the call from the local hospital to move a patient from one facility to another. Those days aren't really there. 911 services don't want to be taken out of their geographic coverage area for long periods of time, which we're talking 2 or 3 hours if we have a transport to Baltimore. So we had to come up with a solution for how we address our own internal system transportation challenge. So in working with our Chester River Health Foundation, which is the prior name for the Shore Medical Center of Chestertown, they've made almost a $300,000 investment in having a dedicated ambulance service at our Chestertown facility. And we were expecting about 100 transports a month, but we're closer to 200 now. But I think one of the amazing things through this is we did a 6-month pre-post study, and we've reduced the wait time for patients to be transported from Chestertown by almost 6.25 hours. So that's a significant reduction when you're talking about getting folks to the most appropriate level of care and preventing any further harm because they have any delay in resources. I want to spend a little bit of time talking about our mobile programs. So we participate in sort of 2 different approaches to mobile health. We have our Shore Community Outreach Team, which is a Shore-sponsored mobile health program staffed by a nurse, community health workers, and a social worker, with a pharmacist available via telehealth services. We've launched that program in Kent County and Dorchester County, 2 of the counties with higher disparities, and it was a part of our rural health hospital designation to have this program in Kent County. They do home visits and a lot of community outreach. Additionally, 2 of our 5 counties through the health department have stood up mobile integrated community health programs. So that's working with the 911 services. They also have nurse, paramedic, and social work. Some have substance abuse or peer counselors. They're looking at primarily at high 911 utilization, and then we, as Shore Regional Health, provide them their pharmacy coverage, and they'll work with us to do televisits for pharmacy. So they have all of the equipment. Both of these teams have all of the equipment to go into the home, set up those telehealth visits, and help those patients connect to care without having to leave their residence and travel the geography. The Mobile Integrated Community Health Program for Queen Anne's County, this is, again, we're fortunate in Maryland because we have CRISP as our HIE. One of the things they allow us to do is load cohorts of patients into the database in order to do pre-post studies on interventions. So we can get some fairly robust data from the CRISP HIE to know whether or not the interventions that we deploy are actually making a difference. And so here you see some of the emergency department utilization and inpatient utilization of the Mobile Integrated Health Program for Queen Anne's County, which again is a county-led, across the 1, 3, 6, and 12-month average. But a 10% reduction over a 12-month period in both the costs for inpatient and ED visits is not an insignificant reduction in costs. and then over a 20% reduction in utilization, again, is a fairly significant impact on our hospital utilization. Switching over to our Shore Community Outreach team, which is a part of our medical center at Chestertown. They offer essentially two programmatic interventions. So they provide community case management. So they will work with identified patients who are referred or we stratify into the program directly for community case management and help them navigate their health-related social needs, their access to care, and supporting them through telehealth visits in their home. And then this team is also very active in the community, participating in community events, doing blood pressure screenings. And then last year we were able to get them CLIA waived, and they're actually doing A1C screenings in the community, so we can identify diabetics or pre-diabetics and start to navigate them to health-related practitioners as appropriate. So in the 2 years that they've been fully active, we've served about 175 people through our community case management program. We've done a little over 1,500 home visits, and this is just within the Kent and Northern Queen Anne's County team. They've completed 50 advanced directives. We've connected approximately 50 patients to primary care. We've connected 50 patients to primary mental health. And again, they're very active in outreach events and health screenings. And then similarly, as we looked at the mobile integrated community health program with Queen Anne's County, here we can see some of the impact based on that pre-post analysis through CRISP. So similar results with ED utilization reduction over a 12-month reporting period by over 20% and a 10% reduction in cost. And significant savings on the average charge pre-post. And again, in Maryland, charge and payment are somewhat analogous because of the rate model. So looking at our Shore Community Outreach team, I also wanted to highlight the partnerships they have within the community. And to me, this is an area where we have some additional work to do. And I'm thankful for the course on collective impact in the MSA or MAS program, because I think there are a lot of lessons learned from there that we need to apply at Shore Regional Health for improving and engaging with our community partners more substantially. The one on here, and I wanted to point out, is Big Mix Beautiful Beginnings. So this is a barbershop and salon located in one of our areas of higher disparity within Kent County, just outside of Chestertown. Similar in COVID, where there was success in partnering with barbershops and faith-based organizations to have them help extend credibility to the health system for vaccinations. Big Mix has been a tremendous partner for us, and through his shop, we host monthly blood pressure screenings there. We do A1C screenings there. We do community CPR classes, and we do curbside Narcan and training there. So our community outreach team and our health educator will go there, again, on a regular recurring basis, engage with the population in that community and look to help them recognize and address their needs and get them connected into care. So again, those non-traditional partners, I think, are some of the most valuable partners that we have. I want to wrap up by talking a little bit about our community engagement beyond the Patient and Family Advisory Council. So for us, and again, this is specifically related to the work out of our rural designated hospital, we have an active community advisory committee. So this is comprised of business leaders, educators, patients, and other nonprofit members to help keep us informed and on the right track in terms of our program offerings. And then we also have, through our Shore Community Outreach team, an African American Health Advisory Committee. Interestingly enough, this started as an African American Women's Health Advisory Committee. The men got a little put out that they weren't a part of it, and they raised a little bit of a stink. So the committee has been expanded to include men. and they offer programming specifically designed to meet the needs of our African American residents in Kent and Northern Queen Anne's County with workshops, seminars, screening, CPRs, and they meet on a monthly basis as well. And we'll be bringing actually both of these groups together in February so we can get a little bit of coordinated programming with sort of the interests of both groups being heard and recognized. So with that, I want to thank you for your time. Appreciate your participation. And again, want to thank Mark and the school for inviting me to be a part of this series. So with that, I'll turn it back over to Mark.
Great, Zach. Thank you so much for sharing your experiences at the on the Eastern Shore, Maryland. We can open it up to questions if we have a few minutes left. So if you would like to put a question in chat, if that's the appropriate process. Or maybe you have to use the Q&A piece.
See anything in chat?
I think the Q&A is open, however, if people want to use that.
Well, while they're giving some thought to that, two things I was struck by, Zach, that I just wanted to ask you about. One is it was that Venn diagram that you showed the various population health management programs within the University of Maryland. You know, I joke, and I saw Deborah Thompson's name there. You know, as care management programs have developed, everybody seems to have their own care management program, right? And I always used to joke, we're going to need a care manager to care manage the care managers, right? Just to coordinate all those activities. So I was interested to hear that you are involved in trying to coordinate the activities of the various population health management activities within your organization, and just thought maybe you could speak to that for a minute or two, just kind of what's going on there.
Yeah, I'll put on my previous hat coming out of the corporate pop health team because that's where a lot of that care management of the care managers is originating from. And so Melissa Huber, who is our director for care management at our corporate pop health group, you know, and one of our previous alum who was in the program, not her, but one of her team members. You know, started sort of working through that problem and figuring out what do we need to do. There had been inpatient care management councils, but there hadn't really ever been sort of any thought given to the ambulatory or outpatient care management coordination. So the Pop Health team stood up an outpatient care management council. They landed on that framework as being the basis to guide that council's decision making and activities. And so they serve as the corporate hub. They're helping to address and manage populations in many of our value-based care programs, in particular the Maryland Primary Care Program. And then we're extending that into our member organization. So the Venn diagram that you saw is actually only the Venn diagram for Shore Regional Health. It isn't inclusive of the other separate pop health programs in each of the other member organizations, which is part of what we're looking to coordinate and align, but to the point where, you know, where local variation is still necessary because of the unique needs of Baltimore City versus Shore Regional versus St. Joe's and Towson. So that, you know, that's sort of the fledgling work there. But, you know, for example, on the low you know, on the wellness side of the need, we've launched a program with our own employee population because we put them underneath our population health program with a company called GOMO. So they're doing text messaging based on chronic condition and low risk in order to help people recognize healthy behaviors. And then all the way up to, you know, the aggressive episodic care management for transitions of care, you know, across the continuum. But you know, that Venn is only a small part of the actual overall Venn diagram for UMS. We are working on systemization. That is a part of our journey.
Well, you raise a great point. I mean, you know, part of the population health management program philosophy is that you really have to target it to the populations that you're serving. So there is going to be, you know, clearly differences but the supporting infrastructure, data systems, et cetera, to support that should be consistent. So I see Craig has a question here. Are you working with vendors, or is I think he means remote patient monitoring program homegrown?
No, so we're working with Vital Care as our vendor for remote patient monitoring. We have monitoring sort of Monday through Friday, 8 to 4 with our population health team. They pick up and do the evening and the weekend monitoring in the event of crisis. We're one of 2 member organizations that is doing this as a bit of a pilot for the system. Upper Chesapeake Health System, which is based out of Harford County, Maryland, they're actually running and managing the program entirely with their own team. So we've had to take a little bit of a different approach, but we are using a vendor for that program. And we got grant funding to provide us to be able to purchase the 100 kits in order to launch the program here on the shore.
Well, I see we're just about at time. So Dr. Topper, maybe I'll turn it back over to you to wrap up.
Thank you both very much. That was a really great presentation, and I'm sure that I know I learned a lot. I'm sure everyone did, and we appreciate your time. We do only have a couple of more minutes, but we can certainly stay on, especially those of us from the MAS program office. Both of our presenters are welcome to stay as well in case anyone has additional questions. We are always happy to make ourselves available and answer those. And in the absence of that, I just want to thank you again for attending and remind you that the next seminar in the series is coming up after the new year on January 9th. So you can look for some email notification about that. And in the meanwhile, Happy New Year to everyone.
Yeah, I want to extend my best wishes for a happy new year and a safe one at that, and happy holidays.
All right. Well, thanks very
All
much
right.
again, everyone, and we'll
All
see you
right.
again soon.
All
Take
right. Bye. Zach, thank you.
Thanks. Appreciate the opportunity and happy holidays.